That's fine. All right, thank you very much. This is my first time in Qatar, and I'm really impressed by the facility and the general infrastructure. I'm also a newcomer in this sports committee, so I really thank Miles and Francois to have appointed me and to have welcomed me. I will try in the next 20 minutes not to show you all the techniques that have been developed in cartilage repair. I will try to do an overview to show you a little bit the state of the research, where we stand in 2010 with respect to this cartilage repair. First of everything, I will start with some reminder for the youngest colleague in the audience. And it doesn't work. Oh, this one. So just a reminder to let you know that cartilage is the most sophisticated tissue we have in the musculoskeletal system. And we receive one cartilage for the entire life, and we are very, very quickly old in terms of cartilage, because probably at 14 years old and 16 years old, respectively male and female, we are not able to regenerate the cartilage surface. A second thing is cartilage lesions are very common when we look at the different arthroscopy that we can do in the knee. But one thing I wanted to point out on this slide is the number of grade 3 and grade 4 lesions that have been found in this study. You may see that these are not so common or so frequent, and this is on this type of injury that the cartilage repair technique is implementable. One thing we're talking still about, this is absolutely not osteoarthritis, but this is focal traumatic lesion on big surface, either on the patella or on the condyle of knee. One thing we think, but we're not sure about it, actually we don't have a lot of knowledge about the real activity of cartilage tissue in a normal adult. One thing we think is that the natural history of focal full thickness defect is relatively bad. What happened is that once the subchondral bone has been exposed, this subchondral bone will thicken, will become more rigid. As a consequence, this will increase the load on the margin of the cartilage's lesion, leading to to increase in shearing forces, and therefore a peripheral chondrolysis. In other words, that will just expand the size of your lesion and aggravate the state of the adjacent cartilage. A very first thing, and this is still a reminder, is to define the lesion. And this is really crucial if you want to apply or find a good indication for your different technology. You need to know the position, the size, the thickness, if the defect is contained or not. You need to know exactly the state of the surrounding cartilage. And last but not least, you need to know exactly the state of the subchondral bone. Once again, and very recently, we really get to, I would say, the consensus that the subchondral role play a crucial role in terms of getting a proper healing of your cartilage surface. In order to assess this subchondral bone, we usually recommend either to use arthro-CT or MRI in T2-weighted fat-SAT sequences in a way to really know exactly the size and the severity of your subchondral lesion, and to know exactly what is the consequence of this lesion on your subchondral bone. But not only, you need absolutely to assess the alignment of your limb. It's very difficult for a malaligned joint to heal if you want to resurface its cartilage. Now, what are the novel perspectives? I think the very important thing is to increase the degree of suspicion of any cartilage lesion. When you have a direct hit on the knee, when you have a direct hit on the surface of the joint, beware of any surface, of any damage on the cartilage surface. Do an MRI, do other sophisticated investigation if there are available, but this is very important to try to depict this cartilage lesion. We have new technologies such as D-Gemeric that will look exactly at the quantity or the density of proteoglycan, and this opened the field to new probe that will maybe by chondroplasty help to correct superficial lesion of the cartilage. Same thing for the T2 mapping technology, where once again we can depict early on cartilage lesion and therefore correct the things before it becomes more severe. This is one example. This is a soccer player that just got a knee-knee contact during the game, and he was complaining of anterior knee pain for more than a year when he came to the office. And when you look at the MRI, you can depict this small side node right there, and this was a fracture of the cartilage. You see it here arthroscopically, and we just look at it. It was a full thickness fracture, and we just microfracture it, and this guy was able after 9 months to go back to play soccer. Now, if we're talking about cell therapy, of course we have to discuss the autologous chondrocyte implantation. But more important thing is that autologous chondrocyte implantation has very specific indication. Once again, this concerns isolated lesion. It's bad on the medial condyle. The size of the defect is critical. The depth of the defect is critical. Young patient, according to the technique, can be more or less 45 years, but it can also be more or less 30 years, which will limit the quantity of patients who are suitable to be treated by this technology. Recent lesion is also very important, and very often failed initial treatment or second approach is one thing. But contraindication do also exist in ACI. Patient over 45, once again, this is not the treatment at the present time of osteoarthritis. Small defect, larger defect, kissing lesion, malalignment, I already addressed that, instability, inflammatory disease, meniscectomy, overweight, multiple operations of smokers. This is all contraindication of ACI. Now, obviously, if we go through the ACI, just a few remarks. The story started about 15 years ago with this first generation ACI, popularized by this Swedish team. One of the most striking study in this field was the Norwegian RCT, with now the 5 years results recently published. For me, okay, no difference in between microfracture and ACI was 1 point, but a very interesting result in this study was that whatever the treatment that the patient underwent, there were 1/3 of the patient that had early radiological signs of osteoarthritis. This means that probably in some of these patients, we absolutely did not influence the natural history of the disease. So in Europe, we talk about ACI generation 2 when we are using biomaterial to cover the defect over the cells, over the microfracture, so-called also AMIC technique. AMIC technique with a 3-year results, you may see that on this diagram, is able to improve pain and function in a patient with, once again, focal lesion. Now we're talking about generation 3 in Europe. We're talking about generation 2 in North America, where we use a scaffold that will transport our cells within the lesion. So I just listed here a few of these constructs. Some are made from collagen, some are made from acid hyaluronic, etc., etc. Those are relatively promising. So you can see that type of cases where you make, that was a allograft C implant in this case, where we can see a very nice resurfacing of this cartilage lesion. But it doesn't work always this way. Another generation 3 is the one we have some experience with, this so-called cartilage, where we seed these autologous chondrocytes in agarose and alginate gel, and this has been relatively well validated at the preclinical level in a big animal model, where we see that in this adult sheep osteochondral lesion, the restoration of the subchondral bone and the articular and the cartilage was very interesting. That's why we moved this technology to the clinics, and we made a few implants, and actually this is the team from Lyon made the phase 1 study, and now there is an international multi-center study that is ongoing for grade 3 and 4 traumatic lesion or OCD, testing microfracture versus this cartilage implantation. In this this phase 1 clinical study, you may also see that using the IKDC score at 2 years follow-up, the results were encouraging, but are still very preliminary when we talk about cartilage. Now, for the one of you who are interested in this ACR, I really encourage you to read this review paper from Iris that just been published in the JBJS American, the last issue of the American JBJS, where you see on the right inside of the diagram the positive effect of the different techniques compared throughout the papers published in the literature. You may easily see that there is not really conclusive result on this diagram. Now the problem we have, and this is the problem we have, for example, in Europe, is that when an advisor from an insurance sees that type of diagram, he can easily see that on the left-hand side you have low-cost techniques such as microfracture or even OST, and on the right-hand side you have high-cost technology with the ACI, and obviously his choice is rapidly made when he has to advise the insurance in order to reimburse the different costs. Now, from this cell therapy approach, although this is a tissue engineering approach with the cells seeded in the scaffold, now we move in a one-stage minced cartilage scaffold with this case technology that's been developed mostly in Chicago with Brian Cole. This is still, I may say, under investigation, and I just mentioned it here. Now, for a very long time, we were using purely chondrocyte, but you know that chondrocytes are highly specified and highly differentiated cells, and maybe that if we go a little bit further down the different step of phenotyping of the cells, we may get a better results. That's why all the stem cells technology obviously has been very attractive to the cartilage field. And talking about MSCs, there is preclinical work that has shown in a rabbit model here by Jason Dragoo that you can engineer cartilage pieces from stem cells. You can transplant them, they will be integrated, and they can restore a nice cartilage surface. Now, this technology has been also investigated in human, and in this paper coming from Singapore, you may see that at 2 years follow-up, they have significant improvement in both groups, the chondrocyte groups as well as in the bone marrow stem cells groups, but they were able to show that they have better cartilage, histologically speaking, with the stem cells technology. Of course, gene therapy, which is a big topic in orthopedic, is certainly a very interesting technology for cartilage restoration or tissue engineering. Of course, you can modify the cells and you can modify the stem cells in order to make them expressing the gene of interest, and this gene of interest has been already well identified. That could be TGF superfamily gene or BMPs. And using this type of technology, once again, the proof of principle has been made that if you make your cells expressing, for example, BMP13, you will get a better healing of your cartilage surface. Now, we're talking about cells, but very recently, at the last ORS in New Orleans, we were very surprised to see a control group where the scaffold, for example, in tissue engineering, was placed without cells, and very often the result was very good, even better than with the cells. So one of the major questions that has been raised during this last ORS was, do we really need cells to repair this cartilage surface? We can use growth factors. These growth factors have been now well characterized in terms of promoting or inhibiting the formation of cartilage, and we could use these growth factors to create bioactive scaffold in a way to induce cartilage repair from intrinsic cell that we can find within the joint or in the underlying subchondral bone. Looking at this scaffold, one very promising technology is this scaffold that you can now create it by nanotechnology, where you can reproduce the 3 different levels or the 3 different layers of the cartilage, calcified cartilage and subchondral bone in one construct. And you see here this new scaffold that has been developed and validated in Italy, in Bologna, where once again they conducted investigation on a big animal model with the scaffold plus chondrocyte plus PRP or nothing. And you can see here that with only the scaffold, actually, the results were the better, at least compared to the use of ACI or PRP. And so this was a very interesting finding, and at least this stimulates the Italian team to implement this technology to a couple of patients, and they made phase 1 studies where they treated 15 lesions, and they were able to show that you have a nice integration of the scaffold with some remaining subchondral edema or swelling. But once again, results are encouraging. Now, one very interesting thing with the scaffold is obviously you are not limited in size, you are not limited in terms of cells production. You can place it as they made in this special patient, which was a 46 years old former soccer player, where they placed in 3 different cartilage lesions that you see here intraoperatively. They placed the scaffold, and they obtained at 6, 12, and 24 months relatively nice integration and restoration of the cartilage surface. And I think this is really promising results. Obviously, these results need now to be confirmed widely, and the technology to be fully validated in terms of indication and restoration of the cartilage features. Well, emerging technology, what do we need? Always the same. We need much more basic science work in order to perfectly understand what is the pathology of the cartilage, the mechanisms of this cartilage maintenance or restoration or repair, because we do know that some of these chondrocytes can induce a repair process. This is definitely complex. This is not as easy as we sometimes think with our simplification system. And these requests are the helps of our basic scientists and clinicians in order to move on. Before finishing, I would like to invite you once again to Rio, for sure, but I would also encourage you to mark your calendar and be ready to visit us in 2012 in Geneva for the 15th ESCA Congress. With one specificity, we have a physical therapy course running in parallel with the ESCA meeting. I thank you very much.